Laryngeal mask airway insertion. The laryngeal mask airway, LMA, establishes and maintains a patent airway in the unconscious patient. It's also appropriate for emergency airway and ventilatory support when endotracheal (AT) intubation isn't immediately possible. LMA may also use it in place of a face mask during adult, pediatric, and neonatal resuscitation. The LMA consists of a semi-rigid tube attached to a silicone mask. The mask is placed into the patient's mouth and advanced blindly until it rests above the larynx. The LMA may not protect the patient from regurgitation and aspiration. However, when compared with the bag mask device, regurgitation is less likely and aspiration uncommon. It gained popularity quickly as it had several unique advantages, including the ease and speed of placement, the ability to be placed without direct visualization of the larynx. Also, in the can't intubate, can't ventilate scenario, the decision to use such devices can be used to gain time until help arrives. Terminology. The terminology for these devices can be confusing. The first supraglottic airway device introduced in 1988 was the LMA by Dr. Archie Brain, a British anaesthetist, now also referred to as the classic LMA or CLMA, or simply LMA. An LMA is a supraglottic airway, but not all supraglottic airways are LMAs. Indications: elective ventilation, difficult airway, cardiac arrest, conduit for intubation, pediatric use. Contraindications: absolute, cannot open mouth, complete upper airway obstruction, relative, increased risk of aspiration, suspected or known abnormalities in supraglottic anatomy. Preparation of LMA. Remove the LMA from its package and visually inspect it for discoloration, cracks, or kinks in the tube. Test the patency of the cuff by first withdrawing all air and then inflating it with air injected through the pilot balloon. While it's inflated, visually inspect the cuff for symmetry, and then deflate the cuff. Don't use the LMA if it's leaking air, or if you note asymmetry of the cuff when you inflate it. LMA sizing. LMAs are available in a range of sizes. These sizes are based on the ideal body weight and are a guide only. LMA insertion technique. Gather and prepare the equipment. Assess the patient's level of consciousness. The patient should be unconscious and unresponsive because the LMA shouldn't be inserted into a patient who may resist insertion. Put on gloves and personal protective equipment to reduce the transmission of microorganisms and contact with body secretions. While the equipment is being prepared, ventilate and oxygenate the patient with a bag valve mask device, if necessary. Prepare the LMA by fully deflating the cuff, apply water-soluble gel to the back of the cuff, ensure none is inside the bowel of the LMA or laryngospasm may occur. Hold the LMA like a pen, with the index finger placed anteriorly at the junction of the cuff and tube. Push the mask backwards along the hard palate. As the mask moves downwards, the index finger maintains pressure backwards against the posterior pharyngeal wall, to avoid collision with the epiglottis. Insert the index finger fully into the mouth to complete insertion, stopping when resistance is felt. Inflate the cuff without holding the tube or connecting the breathing system. When correctly positioned, the LMA will be seen to rise slightly in the mouth. It ideally seals to an airway pressure of around 20 cm H2O. Note, this is the ventilation pressure. The inflation pressure in the cuff should not exceed 60 cm H2O. The recommended volumes of air are the maximum volumes, and if a pressure monitor is not available, it is wise to start with half that volume. Often, if there is a small leak in the LMA, after cuff inflation, turning the head either left or right will alter the anatomy enough to remove the leak. First-generation supraglottic devices. They may or may not protect against aspiration in the event of regurgitation, but have no specific design features that lessen this risk. Second-generation supraglottic devices. SADs that have been designed for additional safety and have design features specifically to reduce the risk of aspiration. This category includes ProSeal LMA, iGel, Supreme LMA, SLMA, Intubating LMA, FastTrack. The intubating LMA is specialized LMA designed to help difficult endotracheal intubation. It is rigid and anatomically curved, with a lumen wide enough to accept a reinforced size 8.0 ETT, and short enough to ensure passage of the endotracheal tube cuff beyond the vocal cords. It comes with a tube pusher and a flexi tube which has a removable connector and a soft tip. Cobra PLA. The cobra head borders the laryngeal inlet, holding the epiglottis out of the airway, but the device seals using a cuff in the hypopharynx. Insertion time and success are similar to the LMA Classic, although there may be an increased risk of pulmonary aspiration. Again, it has largely been replaced by the iGel. iGel. The iGel is a single-use second-generation device which has a soft, anatomically shaped, non-inflatable cuff made of an elastomer gel. The gel further molds to the airway shape when it warms to body temperature. Its wider oval design results in improved stability in edentulous, no-teeth, patients. It has separate ventilation and gastric channels. Special considerations. If there's a risk that the patient may have neck trauma, insert the LMA with the patient's neck in a neutral position. Never use extreme force when inserting a LMA. If there's any concern about the final placement of the LMA, remove and reposition the device. Avoid use of the LMA in patients who need high pressures for ventilation. The LMA has a low pressure seal, which may be ineffective when used with high pressures.